starting the next session is something unique session which has been designed by our chairman scientific committee, Namrata Sharma, and also we have with us Dr. Amit Porwal, the member scientific committee. I also invite Professor Rajesh Sinha from RP Center to be part of this session. So I'm Dr. Krishna Prasad Kudlu. I'm co-chairing this session, which is moderated by my dear friend Jasinder Wahi. So let us start straight away with the session on dry eye. So Amit Porwal is going to tell about the basics of dry eye, that is the pathophysiology behind cyclosporine. Over to you, Amit.
Thank you, Dr. Kudlu, Dr. Namrata ma'am and team INTAS for supporting this session. So I'm going to speak on pathophysiology of cyclosporine. So to have an overview of cyclosporine, what is cyclosporine? It is a potent immunomodulator used for treating any immunological disorders. So topical cyclosporine was developed to increase tear production in patients with dry eye disease, and its disease modifying and anti-inflammatory action in dry eye disease is well established. So coming to the pathophysiology of dry eye, we all know that the most common pathophysiology is tear hyperosmolarity and inflammation, which is the core mechanism. So basically it is triggered by the lacrimal gland dysfunction, which leads to chronic T cell mediated immune response and tear hyperosmolarity, perpetuating the ocular surface damage. There is an inflammatory cascade because of this tear hyperosmolarity, which causes release of this interleukin and other chemical mediators. So coming to the tear film, basically the stages of dry and the primary effectors, you can see basically when you have the tear film instability or where there is an imbalance, there is an increase in the cytokine and the immune module mediators, which causes to T cell activation, cytokine release, and this cytokine release further upregulates the interleukin mechanism and again initiates an immune response, and this is a continuous cascade which goes on happening. So there are a lot of intrinsic as well as extrinsic factors in the pathophysiology of this dry eye disease. So where is the role of T cells in this ocular inflammation? The CD4 T cells which infiltrates the conjunctiva and releases the interferon gamma and interleukin 17, resulting in corneal barrier dysfunction, loss of conjunctival goblet cells, and reduced tear production. So we all know what is the function of the cornea and the conjunctiva. Basically, they act as a homeostasis, which is an intact barrier, and the conjunctiva does this by mucin production. And when these two are disrupted, there is a dry eye disease. So basically, we are going to talk about a molecule which is going to target these immune mediators, the release of these immune mediators. Again, coming to the function of the lacrimal gland, the disease-driven mediator and pathologic changes are occurring in the tissue. So basically, lacrimal gland, we all know that it regulates the tear production. So dry eye disease in lacrimal gland disease, basically there is atrophy and loss of acni, fibrosis and apoptosis, and infiltration of the CD4 T cells. So coming to the overview, when we don't have to look at the chemical structure of the cyclosporine. So it is basically a hydrophobic and neutral, making it a challenge to formulate for aqueous solutions. So we all know that cyclosporine is not so easily formulated, and the absorption also is very difficult. So we need different mediators, vehicles to basically use this as topical drops. So ocular exhaustion, it is cyclosporine shows high bioavailability at the ocular surface, but there is poor penetration into the ocular tissue. It is primarily absorbed into the conjunctiva, cornea, and the lacrimal gland, and the half-life varies from 6 to 24 hours. The human absorption is similar to the animals. The cyclosporine concentrates at the ocular surface with minimal intraocular penetration, and clinical trials does indicate that the concentration in cornea and conjunctiva are sufficient for immune modulation without significant change in the systemic or with significant systemic exposure of this molecule. Blood concentrations are very extremely low and undetectable after the topical application, reduces the risk of side effects like nephrotoxicity, which we all are worried about the immune modulators. It is not metabolized in the eyes of the human. Ocular metabolism is unlikely as the enzymatic activity required for its metabolism is low in the ocular surface. So the lack of metabolism in the ocular tissue supports the long-term use of the cyclosporine in topical formulations without significant systemic interactions. So coming to the mechanism of action, basically it causes T cell inhibition, which is the most important mechanism by which the chemical cascade is broken down. There is also inhibition of the nuclear factor. And there is a protective action of cyclosporine against apoptosis by blocking the mitochondrial permeability transitions, providing a protective effect in the conjunctival epithelial cells. So challenges to the topical cyclosporine delivery is very, very important because we all know it is hydrophobic. So ocular barriers, basically the tear film turnover, blinking and necroresinal drainage reduces the bioavailability of this molecule. The lower bioavailability, that is less than 5% of the cyclosporine is absorbed when administered topically. So poor water solubility complicates the creation of an ophthalmic dosage for that is both stable and effective. So traditionally, we have the oil-based formulation wherein the vehicle used is the castor oil or the olive oil, which has been tested but presented challenges because of the burning and the irritation which causes, which the patient has after installation of this drop and this barrier, these vehicles are used. So there is an innovative cyclosporine delivery system which is developed now. It is semi-fluorinated alkenes. It provides enhanced spreading over the ocular surface and reduced adverse effects. Basically, cyclodextrin nanoparticles is used. It includes the combination of alpha and gamma cyclodextrins, where alpha cyclodextrin solubilized 0.05% cyclosporine aqueous solution, and gamma cyclodextrin promotes the formation of nanoparticles. So this nanotechnology basically helps in encapsulated cyclosporine, improving its solubility and penetration through the ocular tissue. So what are the benefits of the nanotechnology? It decreases the time to symptom relief. After single topical dosing showed higher drug concentration in the cornea and conjunctiva. It has enhanced patient persistence with therapy. And just a short video of what is this nanotechnology, I'm just going to show.
Inflammation, a common cause of lacrimal gland dysfunction, leads to disruption of ocular surface homeostasis. Cyclosporine, clinically proven to suppress inflammation, has traditionally been formulated as an emulsion due to its high lipophilicity. The poor aqueous solubility of cyclosporine presented technical challenges in drug delivery to the ocular surface. Now in India, a truly preservative-free aqueous-based cyclosporine formulated with NPL technology is available to meet these challenges. NPL is a biomimetic natural lipid that enhances solubility and stabilizes lipophilic cyclosporine in aqueous base. On administration, NPL-based cyclosporine crosses tear film barrier without compromising the integrity of cyclosporine molecule. On the targeted site of action, lipid component is washed away along with the tears, leaving cyclosporine on the ocular surface. Thus, enhances drug bioavailability and addresses delivery challenges. Aqueous-based cyclosporine with NPL technology may decrease the time to symptom relief, improve tolerability as formulated at pH 7 and patient persistence with therapy.
Basically, those who have used cyclosporine molecule, especially they were available with the castor oil based formulations, the patients were not happy at all and the compliance to therapy was very less. With this new technology, the absorption is only on the ocular surface, and this technology, the acceptance is more, patient is more comfortable, and that's how cyclosporine with this new technology acts. Thank you.
Thank you, Dr. Amit. Excellent talk. One of my favorite drug in the management of cyclosporine. I use every alternate patient cyclosporine. The advantage is much more. I think even the nanotechnology from Cyclysis PF really helps the patient also with a affordable cost to the patient. So I invite our Chairman Scientific Committee, All India Ophthalmological Society, none other than Professor Namrata Sharma. She is going to talk about her most favorite topic, that is a paradigm shift in dry eye management. Over to you, madam.
Amit, in the meantime, Dr. Namrata is getting ready. What doses schedule you advise for this cyclosis?
Dosage.
Yeah.
At least a year. I mean, you
6
have
months
to
and
use
beyond.
at least more than 6 months for the total effect to occur, and we should not stop. We have started it already 6 months or 1 year. We have to continue for a long time, and as I mentioned, there's no systemic side effect and there's no ocular side effect. So we should continue for a longer duration.
Thank you. So, a dry eye treatment has been ever a challenge from times to time, and now we have Professor Namrata Sharma. She'll be talking on a paradigm shift in dry eye management. All over to you, ma'am.
Thank you. Dry eye disease, if you look at the prevalence, and there are a couple of studies, one from Eastern India and one from North India. North India was done at our center. So from Eastern India, the incidence has been reported between 18 to 54%, and from North India, 32%, and this was also a study which was published much earlier. So I feel the dry eye disease incidence is actually much more than this. And this was in the hospital, that means it was at a tertiary eye care center. Both of them were tertiary eye care centers, but in general, I think it is much more than this. So this is the study which was published, and we looked at the moderate and the severe dry eye disease incidence, and we found that close to 30% of our patients were having dry eye disease. Very nicely, Amit has summarized that inflammation is the pathology in dry eye disease, and so it is important that you control the inflammation, which can be done by anti-inflammatory therapy. Currently, we have cyclosporin, tacrolimus, lifitegrast, 3 drugs which are available, but cyclosporin remains the one with the longest track record as of now, and also which was the one which was available to us the earliest. The mechanism has been talked about, so I will skip this part. Suffice it to say that you need to give topical cyclosporin because you need to break the vicious cycle which is there of inflammation. And in these cases where inflammation is there, you can start with the topical steroids and then give topical cyclosporin as well. And then because topical cyclosporin starts to act, it begins its action of onset of action in 6 weeks, and then the action is maximum at around 6 months. So it is important that you start it with topical steroids, so that when you are tapering the topical steroids, this kind of takes over. So these are the steps at which it should be started, and when you have stage 2 or grade 2 dry eye, then you should start the topical steroids, and they have a role to play, and so also the topical cyclosporin. Now, response, if you see, like I said earlier, initial 1 month, the maximum response comes in 6 months, but it starts to act at about 6 weeks, and so one has to be compliant with it for its complete action, onset of action. There are various oil-based formulations which were there earlier, and it can be with preservatives and even unims, but cost effectiveness remains an issue there. Oil-based emulsions will have decreased bioavailability and may cause more stinging. Benzalkonium and ethanol have its own cytotoxic effect, especially on the conjunctiva and the corneal epithelial cells, and so will disrupt the epithelium. And this mechanism, I think, very nicely has been highlighted in the video, so I will not talk about it, except for the fact that it comes in a different kind of a bottle, which is a preservative-free multi-dose eyedropper, which avoids the need for preservatives and prevents bacterial contamination. There are non-return valve, which ensures that no contaminated liquid can be reintroduced into the container after the drop has been dispensed completely. And it also has the basis of pure flow technology, which means that the intake of air into the dispenser takes place by separate venting system with the silicon membrane, which is called pure flow technology. And then the drops are calibrated, so it is going to be neither more nor less, but about 40 microliters. So this is how the bottle looks like. If you look at the meta-analysis of the randomized control trials on topical cyclosporin for dry eye disease, it is very clear that it does improve the tear breakup time and also improves the fluorescein staining score, and these are the results from therein. Now, these are the various topical formulations which are available and which have been reviewed in literature as well. And this is just to see, to assess the prognosis of dry eye with patients treated with cyclosporin A or with artificial tears, and also to assess the reversibility of the benefits of cyclosporin A after switching the treatment dry eyes to patients to complete 1-year course with artificial tears, etc. And it was found that even after you actually take it off, some amount of effect does remain for a good amount of 3 months. And so when you are putting the patients back on cyclosporin, you should always at least follow them up for 6 months. This is the study which was done at our center, role of 0.05% topical cyclosporin, the cyclisis PF, which comes from INTAS, and this was a prospective case series of 80 eyes of 40 patients, and these were the baseline parameters. The subjective symptom scores did improve, and also the Schirmer score, conjunctival staining score, and the tear breakup time. And you can see that all these parameters are significantly different. So these are some of the results from there. So this is a case which was inflamed, and after treatment it does become non-inflamed and there is no staining. Then impression cytology did show that the goblet cells became optimum after the treatment with cyclosis PF, and this is yet another case which healed on topical cyclosporin 0.05%. This was a one-night patient with dry eye which was treated, and this was yet another patient with rheumatoid arthritis treated with cyclosis PF with good results. So in our study, the results that I showed you were the interim results. Now, at the conclusion of the study, the results have been reanalyzed, and basically we looked at 50 patients with dry eye disease twice a day used for 12 weeks in addition to the conventional treatment, and we looked at the parameters at day 0, day 30, day 60, and day 90. And क्या हो रहा है? एक सेकंड स्किप करना पड़ेगा इसको, अब लगाना पड़ेगा। अब देखो, ये है HTML. So basically, this was a prospective study of 50 patients and 100 eyes, and we used cyclosis PF in these cases. And patients more than 18 years of age with OSDI more than 18, tear breakup time of less than 10 seconds, tear meniscus height less than 0.25 millimeter, Schirmer test of less than 10, they were included in the study. And the exclusion criteria was if they had any inflammation or who were not willing to follow up. इससे भी नहीं है, but how come अभी तो आ रहा था? Okay, let me.
I think before they just connect a couple of questions, I just heard most of Madam's presentation that for every severe dry eye, she starts with steroids. So what is the preferred steroid you use in dry eye management, Madam?
I don't start with the topical steroids, but if there is an inflammation, then I would give topical steroids, and
Which one?
we'll give a
Prednisone?
low dose topical steroids
Oh.
first, and then subsequently add topical
No,
cyclosporin.
some of your previous talk I heard that in severe dry eye you started prednisolone also.
Yeah. So moderate or severe dry eye is different. There you would want to start with the full-on steroids, that is prednisolone. But for mild dry eye, one can start Lotepred or FML, although I firmly believe that those really don't help much when you have to start steroids, and when you are actually thinking of breaking the vicious cycle, then you have to give it full on.
My next question, all your refractive patients, sir, do you start cyclosporine?
So all our refractive patients, we did not start cyclosporin, but there was a study which was conducted again at our center which showed in up to 6 months follow-up that all the refractive surgery patients.
Yeah. Madam, you can just continue.
No, but where is it? Okay, I'll have to. Okay, I'll just एक minute there. So I think I've already talked about the exclusion criteria. Next slide, please.
Next slide.
No, we can finish it. Don't. So there were 27 male patients. 23 female patients, and most of the patients were from urban population because that is our population which is generally there. And these are the results. If you look at the tear breakup time, the Schirmer test, the lower lid, the tear meniscus height, the lipid layer thickness, the non-invasive breakup time, and the corneal staining as well as the OSDI. So in all the parameters, you can see that there is a difference which was statistically significant. And for instance, tear breakup time from 2 at baseline increased to 5.4, which is quite a jump. Likewise, Schirmer from 7 to 11, and likewise for the other scores as well. So this is again just to show that from 2 it has increased to 5.48, and at all follow-up points this was statistically significant. Likewise, Schirmer from 7 to 11, again a statistically significant improvement, and the lipid layer thickness increased from baseline value of 31 to 38, which was also statistically significant. And although even tear meniscus height, it increased from 0.18 to 0.24, which is near normal, and so was the non-invasive breakup time, which also statistically improved. In terms of corneal staining also, which was graded, there was improvement, and the meibomian gland loss in the upper lid and the lower lid at the baseline, which was less, also at 3 months it increased, and after 3 months follow-up, it did not change. Ocular surface disease index, again, from 28 came down to 16, which was statistically significant. And on follow-up at 1 and 2 months, there was a statistically significant improvement in the OSDI score. So there were no adverse events as far as the safety is concerned. 5 patients did experience mild adverse reaction in the form of slight stinging, but no patient discontinued the drug, and all the patients, they followed up their, all the patients completed their follow-up. So to summarize, there's a consistent improvement in the patient comfort and satisfaction with the use of preservative-free cyclosporin 0.05%. All the parameters did improve, which I have already discussed, and this cyclosporin 0.05% preservative-free aqueous-based solution with novel proprietary lipid technology does enhance the drug bioavailability and help in the targeted drug delivery, and helps to decrease the time to symptomatic relief, and has improved tolerability, mainly because the formulation is done at pH 7. Novelia multi-dose closing tip system is the crown, or is the added advantage, and this should be used and can be used for patients of dry eye. Thank you so much for your kind attention.
Thank you, ma'am. Ma'am, just one more question. What is your experience that, what is the general tolerance level of people who are using this drug? Do they really feel stinging, or they are just as comfortable as other normal drugs?
So, like I said, 5 out of 100 here, so it was 5%. But this was a prospective study, and we asked for it, because as per the performa, we had to ask for it. But in case, if you don't ask for it, then maybe there are fewer patients. I mean, at least with this, not talking about
With
others.
this aqueous-based one?
Especially with this, not talking about others. But in the prospective study, the stinging or the burning sensation was 5%. But you have to advise them to put a lubricant first, then wait for some time, and then put the drug in case there is stinging. One is this. Second, you can also ask them to cool it a little bit. That also causes less amount of stinging.
Now, supposing we take this medicine for moderate to dry eyes, or those who are really having an inflammatory component. So if today is day 0, by how many days the relief starts coming to the patient? Is it day 15 or 30? What do you feel? What is your experience?
So in general, I think it takes about 6 weeks for the onset of action, or maybe 4 weeks for the onset of action,
4
because
weeks.
this is a preservative-free technology. But I feel stinging is also less because of the preservative-free effect.
Okay. So what we conclude is that there is a good amount of acceptance for this aqueous base as compared to the oil-based drugs.
oil
Okay.
based.
Thank you so much.
Even the pH of this formulation is 6.9.
7.
So yeah, 7. So that's also one of the reasons why the stinging is less.
Okay, thank you, Dr. Rajesh. I think now I invite Professor Rajesh Sinha to talk on
Yes, you have one question, ma'am? Yes, please.
Yes.
Chronic disease, and the effect comes at nearly 6 weeks, and the dry eye is continuing. So supposedly we give it for 6 months and we give a break. Then how long should we give the break and then again begin, or should we give it lifelong? What should be the longer
So we have
protocol?
given, I mean, I have patients who've been using this drug for 5 years plus, but what I generally do is that I would like to give them, give this drug to them for a year and then give it a break. And I would give it a break for at least 3 months, because what happens is that once you've given cyclosporin, the residual effect does remain for the 3 months. So even if you stop it today, for about the next 3 months it will remain. So to say that you don't need it, you should follow up the patients for 3 to 6 months.
But in general, we presume that if a patient gets benefit from cyclosporin, he is a lifelong patient for cyclosporin.
No, some patients are there who are not adhering to the dose. Rather than twice a day, they'll just give once a day and still be happy with it. So you cannot say lifelong. If you want to stop it, you can think
Few
of stopping
breaks.
it at 1 year and then see how it goes. Because basically this is also breaking that vicious cycle which is happening. So once you break that vicious cycle which is going in circles, then it kind of puts a break to it.
Thank you.
Yeah.
So
Okay.
recommended is that you give a break after 2 years if you ask me.
Better to crush the disease, yes.
Yeah, if you see the literature says you should give a break after 2 years.
Okay.
I give it after 1 year, I mean, because see, for us it is a little different. We use it a lot more for allergic diseases also.
Yes, ma'am.
We don't use it only for dry eye.
Yeah.
So for allergic eye disease also we use it quite a lot. We use it in number of...
Even for VKC also?
Huh?
VKC also?
Yeah, for VKC, for graft rejections, for
Graft rejections.
allergic eye disease, for dry eye,
Yeah.
for adenoviral keratoconjunctivitis, nummular opacities to disappear.
Hmm.
People
So
use
it's a
it
wide
for
spectrum.
keratoconus also, so that they don't do eye rubbing and it doesn't progress.
Exactly. Thank you, ma'am. Thank you so much. Let me take this opportunity to introduce and invite Professor Rajesh Sinha. He is a corneal and cataract and refractive surgeon from RP Center, New Delhi, AIMS. Refractive surgery is a component where we touch the youth, teenagers' eyes. So they are the really virgin eyes, and we have got a very, very less margin of error. Now, outperforming a beautiful refractive surgery, but optimizing the visual outcome is a great aspect which has to be dealt. And all over to Professor Rajesh Sinha.
Thank you very much, and thanks Intas for having me here. I'll be talking about, as you very rightly pointed out, that you do a refractive procedure and you expect a 6/6 vision, and apart from that, patient should also feel the crispness of vision. So all that you want, and what actually happens that after any corneal based refractive procedure, dry eye is something that invariably happens to large majority of patients. Some may be symptomatic, some may not be symptomatic, because mostly we prescribe these lubricants in the immediate post-op period. So it is definitely a significant issue, and because when we do LASIK or any refractive cornea-based refractive procedure, we cut the nerves, and that is why, because the nerves are cut, the stimulus is deprived, this neuronal loop is broken, it is cut here, and so the stimulus doesn't go to the brain, and this secretomotor nerve impulses to the lacrimal gland does not go, and I mean it is reduced, and that's why you have chances of dry eye. It is more often seen with people who are contact lens wearers, long-standing contact lens wearers. More with a narrow hinge flap means you are cutting more, and of course with the surface ablation it is lesser. When femto LASIK started, there was a hype created that probably it will not have dry eye, but no, there are studies that have shown that there is no significant difference as far as the femto LASIK or a microkeratome LASIK is concerned. As far as surface ablation is concerned, yes, it is less. Why? Because you have to understand the neuronal branches, the neuronal plexus that is present. There's one subbasal plexus, one is subbauman plexus, and then you have stromal plexuses of nerves. Now, when you do a surface ablation, you do damage the subbauman and the subbasal plexus, but the stromal plexus is preserved to a large extent. When you do LASIK, you cut the nerves, you cut the subbauman, subbasal plexus, and then you ablate, and then you damage the stromal plexus. And when you do a smile, then what you do is that you remove a lenticule. So you preserve a large majority of subbauman and subbasal plexus, but you remove the stromal plexus. And that is why dryness is most often seen with LASIK and less with PRK and less with smile in the early phase. Gradually the nerves regenerate and then things become better. Maybe at 6 months' time it becomes comparable. But this is what is the graph that has shown the recovery of the corneal sensitivity. So this is, the blue one is for the surface ablation, that is PRK, the green one is for smile, and the red one is for LASIK. Suddenly it dips down the corneal sensitivity, and then gradually it improves with LASIK. But with smile it dips down less, and then it improves, and with PRK it is the best. And this was a survey that was conducted amongst the dissatisfied patients after LASIK, and they found out that 1 out of 5 were dissatisfied because of dry eye. And of course, sometimes we prescribe drugs with lubricants, and that causes toxicity. So what is the management? What we do? We prescribe lubricants in all the cases of post-refractive surgery, whether it's a PRK or a LASIK or a smile. So artificial teardrops is the mainstay, of course, and we have to prescribe it at least for more than 6 months, sometimes a year or so. And preservative-free lubricating drops are preferred ones. Now, what is an ideal polymer? An ideal polymer is the one which should have a good wettability, optimal viscosity, osmotic protection, good electrolyte, etc. CMC is something which has been used for the longest period of time, and it has a good mucoadhesive property, and that is why it is many times accepted. But hyaluronic acid of late has come up with very good results and has shown great promise, and that is why many people have started preferring hyaluronic acid. And polyethylene glycol with propylene glycol and HP guar combination also is a drug which is an option. But then a large majority, there was a question that whether you prescribe cyclosporin in all your post-refractive patients. Well, the answer is no. But there is a certain segment of patients who do have surface inflammation, so you can start, or they have preoperative mild dry eye, or they show subtle signs of inflammation, or they don't improve with the lubricants prescribed for a couple of weeks. In all these patients, you have to prescribe topical cyclosporin in order to improve the surface, because it is an FDA-approved drug and it reduces the inflammatory mediators and reduces the surface inflammation. So these are some of the studies which have shown that cyclosporin does help. This is one study by Canalopoulos group, and they have shown that topical cyclosporin treatment is an effective alternative in management of LASIK for myopia-related transient dry eye. And this is another study that has concluded that topical cyclosporin A is an effective therapy for refractive surgery patients and dry eye that has worsened. Many times, when you give lubricant, the patient still is symptomatic, and then you have to give cyclosporin. This is another study which has shown that it is an effective treatment for reducing the time needed for visual recovery after LASIK. Why? Some of the patients of LASIK will read 6/6. I'll just take 1 minute more. Will read 6/6, but they will have that subjective feeling of blurriness. So all these factors are there, and that is what has been shown in studies, that when somebody who has been using cyclosporin, they have this feeling much better, and they have faster recovery of vision. This is another study which has shown that the role of cyclosporin is there to improve the recovery of visual acuity post LASIK. Another study in this direction, and this is another study which has shown that cyclosporin is an effective treatment for reducing time needed for visual recovery, and another study which has shown that cyclosporin has shown to be it improves corneal sensitivity at 3 months after LASIK. So this means that if the sensitivity increases, then the tear secretion will improve, and that is how it will take care of dry eye. There are some formulations that are oil-based formulations present in the market, which are emulsions, and they have decreased bioavailability, and they do cause some degree of stinging as well. And these preservatives, they also cause stinging. So this is one product which is preservative free. This PF stands for preservative free, and this is an aqueous formulation which has been very nicely presented by Dr. Amit and Dr. Namrata. And this has a pH of 6.9 or 7. And that is why, because of the aqueous preparation and because of pH being same as tear film, then the irritation in the eye is not there, and it is specially packed in an Novelia bottle, so the contamination risk is also not there. So in conclusion, cyclosporin eye drops, they are actually therapeutic. They increase the goblet cell density, they have a therapeutic role in dry eye, and they are disease modifying drugs. But yes, it takes some time for the drug to act. It takes some duration, as was mentioned in the study as well, that you need to prescribe for a few weeks in order to get some effect. So in conclusion, dry eye, yes, there is a high risk after corneal refractive surgery. Controllable factor is you can reduce drug toxicity, treat the preoperative dry eye, give preservative-free lubricants, and of course reduce surface inflammation by cyclosporin, preferably preservative-free. And last but not the least, patient education and counseling is very important. Thank you very much.
Thank you, Rajesh, for excellent talk. I think we are concluding the session. I think thanks INTAS for conducting a wonderful session. Thank you, one and all.
Thank you so very much.